It's about a minute to 3 Central African time. We'll be starting shortly. Okay, 15 hours on the dot, Central African time. A warm welcome to today's BLN open discussion on the introduction of the COVID-19 vaccine with lessons from Zambia. A very special welcome to the discussion moderator, who happens to be from Uganda, and our guest speaker from Zambia. I am Catherine Miawala, the BID Learning Network Coordinator, as your host. And as many of you know, the BID Learning Network is a peer learning platform led by PATH. And we welcome you to this fourth webinar in the series on the experience of lessons learned from the COVID-19 vaccine introduction in Africa. And it's our sincere hope that these interactions that we've been having over the months will promote mutual learning amongst the public, private, and international healthcare practitioners, as well as policymakers, program implementers, researchers, academia, among others. Now, before we begin today's business, maybe I could run you through the housekeeping rules. In the chat box, would appreciate if you type in your name as a participant and the country where you're connecting from. And of course, if you're sharing the same connection with a number of colleagues, please type in the number of colleagues, not necessarily the name, but just the number, as per example shown on your screen. And also we encourage all the participants to remain muted and have their videos disabled. Of course, we want the discussants to speak without interruption, and also that we don't affect those ones who've got very low internet bandwidth. And also to let you know that there will be a question and answer session at the end of the discussion. And for those of us who may have burning questions, so that you don't lose your train of thought, please type in your question in the chat box. Don't feel inhibited, just type in your question in the chat box. So be logged and answered during the question and answer session. And also just to let you know that this webinar is being recorded and that the link to the recording will be shared via the various learning network platforms like the Google Groups and the BLN website. So to take us back to today's business, where we're talking about the introduction of the COVID-19 vaccines in Africa. It's been over a year into the COVID-19 pandemic, and we have also seen how the world has become subdued by this pandemic. We've seen health services being disrupted. We've seen morbidities and mortalities increasing, and generally we've also witnessed the socioeconomic systems being thrown into disarray. So according to WHO, the pandemic has actually claimed about 4.3 million lives globally, with more than 200 million people being infected. But fortunately, we have seen over 4.4 billion vaccine doses being administered globally, of which close to 75 million have been administered in Africa. We are sincerely grateful to WHO, UNICEF, Gavi, the Vaccine Alliance, and many other partners who've worked tirelessly to ensure that the countries around the world have access to this much needed vaccine. And of course, we know this includes about 52 countries in Africa where they began deploying the vaccine rollout as early as February 2021, and most of them are now in the second phase of rolling it out. So in the last 3 webinars, we got to hear experiences about the vaccine rollout from Cameroon, Liberia, and Malawi. Today, we get to hear from Zambia about their journey on this exercise. And of course, to lead us in today's discussion, we're indeed honored to have Professor Josephine Nabukenya, who happens to be the peer advisor to the BLN from Uganda. Welcome, Professor. It's great to have you on the platform. Now, Professor Nabukenya is from Makerere University in Uganda, where she's currently the Deputy Vice Chancellor. Wow, congratulations, Professor, from the last time that we met. This is great, congratulations. And she happens to be a seasoned health informatics professional and researcher. She's chair of the Health Informatics Research Group in the School of Computing and Informatics Technology at the same university. She's also a member of the Uganda eHealth Technical Working Group and Digital Health and Interoperability Working Group of the Health Data Collaborative. Professor Nabukenya was also part of a 10-member core team that developed the Uganda eHealth policy and strategy. And she's been quite instrumental in supporting the Ministry of Health during its implementation. She's also been spearheading the development of the eHealth enterprise and interoperability framework for the health information exchange in Uganda, and the automation of various national registries, which include the national client registries. There's also the health workers registries and the health facilities registries for Uganda. Professor Nabukenya has also spearheaded the development and implementation of the PhD and Master of Science in Health Informatics program at Makerere University. She's an ardent member of the ICT societies, including the Association of Computing Machinery, Enterprise Engineering Research Network, and the Group Decision and Negotiation Network. And like I've mentioned earlier, she's also a member of the BID Learning Network Peer Advisory Group. Professor Nabukenya, a warm welcome to you, and it's good to have you moderate our discussion once again. I will now hand over the floor to you to introduce our distinguished speaker, Mrs. Bianca Chifuelu Chiwenga, and lead us through the discussion. Professor, over to you.
Thank you very much, Catherine, and a good afternoon to everyone. I'm glad to be part of this team, and for the webinar, Catherine has just quite comprehensively elaborated on its goal and what we'd like to achieve. We are here to appreciate what the Ministry of Health, Zambia, has achieved through their lessons during the COVID-19 vaccination introduction and its implementation in the country. So before us, we have Bianca Chifuelu. I will not pronounce the last name. And Bianca is a program officer with the Expanded Immunization Program at the Ministry of Health, Child Health Unit in Zambia. She has over 13 years experience working with the rural and peri-urban public health. Her role involves providing technical support for planning, implementation, and monitoring of routine immunization and COVID-19 activities in Zambia. She also supports the implementation of Gavi, health system strengthening activities, and capacity building of health workers for more effective communication and performance of the immunization program. Bianca also has experience in the field of water, sanitation, and hygiene education. She holds a BSc in environmental health, project management from Musanga University, certificate in Zambia field epidemiology from the Zambia National Public Health Institute, CDC, and a certificate in project management. Bianca is passionate about working with children and providing mentorship to health staff in districts to help them to improve their routine immunization coverage. Bianca, you're very welcome as our main speaker this afternoon. As a team and listeners, we look so forward to these lessons and carrying them forward to our respective countries. Over to you, Bianca. Would you like to say something before we can get through the afternoon?
Thank you very much, Professor Nabukenya. You see, I also can't pronounce your name clearly, but the last name is Hiwengwa. Thank you so much.
Okay, I'm happy to be called by Josephine, just to quicken the conversations.
Okay, thank you.
Yes. So, Bianca, would you like to tell the listeners how Zambia arrived at the decision to introduce the COVID-19 vaccine?
So the Zambian government recognized the need of a vaccine when it became clear that the COVID-19 disease was here to stay and the government would need the vaccine. So there was basically an involvement of the technical team within the government, which included ZNPHI, with Zambia National Public Health Institute, the Zambia Immunization Technical Advisory Group, the ZITAG, and other technical partners who support the routine immunization program. And thirdly, there was engagement of potential support sources or entities, including the COVAX. So in 2020, on 21st July, the Zambian government, through the permanent secretary, took part in the group consultation, which led to Zambia acknowledging that they were eligible for the COVAX application. So Zambia made a commitment to be part of the facility through a statement made by the permanent secretary. The Zambian government submitted the vaccine request on the 7th of December 2020 to Gavi, the Vaccine Alliance, and the confirmation for participation was received on the 22nd of December 2020. Though the Gavi co-financing was not clear by them, but the funding mechanism had three options. There was 20 to 80 or 50 to 50 or 100% against the country. So the country went ahead and developed the NVDS, which is the National Vaccine Deployment Plan or Strategy, as part of its preparation for the vaccine deployment. So on 18th February 2021, the NVDS was accepted by the Regional Review Committee under the COVAX. For all this, all the stages or the processes was done through the Zambia Immunization Technical Advisory Group, which is a ZIDAG, which gave recommendation at all points or stages of the preparation. Thank you.
Wow, that's quite interesting. What are the challenges that Zambia has encountered in the introduction of the COVID-19 vaccine in relation to the preparedness, vaccine delivery, logistics and cold chain issues, financing the vaccination implementation, identifying target population, and vaccine hesitance due to misinformation, myths, and misconceptions? Bianca, for you to be able to help our listeners to understand, let us break it up into 5 aspects. So could you speak to the listeners about the challenges Zambia encountered when introducing this vaccine in relation to preparedness?
Thank you. So some of the challenges that were encountered during preparedness were the short time that the country had for the preparation and meeting of deadlines, including the planning for multiple types of vaccines and also preparation of the NVDS. So the other challenge is that most of the planning was done virtually due to the COVID-19 restrictions that were laid down. And then planning for orientations of health workers and other staff was done in a haste. This resulted in orienting only the first staff that were earmarked to do the initial selected centers. So the other challenge in preparedness was that the vaccine information was not enough at the time of implementation. Thank you. Or should I go ahead and talk about the challenges in vaccine delivery?
Yes, please proceed.
Okay.
Thank you, Bianca.
So under vaccine delivery, logistics and cold chain, there are also challenges. Some of them were delayed mobilization of funds for distribution of the vaccines, because the vaccines were supposed to be distributed to the rest of the country in all the 10 provinces. So also the other challenge was immediate transport to distribute or redistribute the vaccine, which is limited. We have limited immediate transport available. Then there's high wastage related to the low uptake by the first prioritized target group. as a country, we had prioritized our target group in tiers. So the first prioritized group was not eager to take the vaccine. So that was a challenge in that it led to wastage. So there was also multiple dosing, difficulty in managing subsequent doses. Then the other challenge is that the vaccine was new, which had no VVM. So that led to a challenge in logistics, because that's the time that we're receiving the vaccine without the VVM. Then there was short life of the vaccines that we received. As a country, we received the first batch on 12th April. And then that batch which we received was expiring on 29th. So for it, the time was short because it's supposed to cater for 2 doses. Then challenges under financing and vaccination implementation. We didn't have, we had no operational support in form of vaccine introduction grant that is usually provided by Gavi with the other vaccines. Then during implementation, we had partial funding for the activity. In here, basically, we didn't have funding for all the stages, but you find there could be support, a bit of support for training, but other parts or other stages could be neglected. So challenges in identifying the target population. This one, I've already stated that as a country, we had the targeted population divided in different groups or tiers, as we can say. So there were those who, the first group was for essential health workers. Then there was those most essential to maintaining core societal functions. Then the third group was those greatest risk of severe illnesses. And the fourth was population in congregate settings, and the other group was the rest of the population. So here, the challenge was we were finding it difficult to identify a certain target population. For example, the people with comorbidities, it's difficult because when we go on the ground, we were not able to have the actual number of the people with the comorbidities or non-communicable diseases. Even people like those in UN agencies, it was a bit of a challenge to identify them. And then this has also led us to have some defaulters, especially for the second dose for the AstraZeneca vaccine. So the other challenge under the vaccine hesitancy due to misinformation and myths and misconceptions, there was inadequate time to conduct sensitization meetings before introduction of the COVID-19 vaccination, which brought about the low uptake of the COVID-19 vaccination, especially among health workers. The other challenge was that the lack of adequate vaccine information to counter the misinformation, because when we started, there was a lot of information that was out there. So the health workers really needed adequate information to really counter the misinformation. Thank you so much.
Bianca, that is quite interesting. These challenges are actually not very unique to Zambia, but there's much to learn from them. I personally, who was coordinating on behalf of Makerere University COVID Task Force. So, based on those challenges, what do you think Zambia can put up as strategies to address them?
As Zambia, a lot of strategies have been put in place. So basically, the program has an outreach approach. So some of the strategies include multiple service delivery points, such as static, mobile, and also outreach. So we also have challenges which resulted in virtual orientations. So for this one, we recommended that apart from virtual orientations for the staff and everyone that will take part in the program, also it should be followed up by support in on-site mentorship. So then any type of vaccine or a new type of vaccine that came in was always accompanied by an orientation, which is either virtual or on-site, including and updating the provision of the orientation packages. Then the other strategy was realignment of the activities with the routine immunization activities within the country. Then the other strategy is the updating of weekly updates with the stakeholders. As a country, we have a weekly COVID-19 technical group, which is comprised of a number of stakeholders, where updates are given on how we've moved in our COVID-19 vaccination implementation. But take note that the first 4 months of the implementation, these meetings were held twice in a week. But for now, we are holding them once a week for update. Then social mobilization at all levels, especially dissemination of the latest vaccine information and recommendation to counter misinformation. This one is important. As we receive any new vaccine, we need to make sure that we've made sure that the information is spread across all levels up to the service delivery site or point. Thank you.
Wow, thank you, Bianca. So you just told us quite a number of challenges during the introduction of this COVID-19, but we didn't hear much about the vaccination data. So how is Zambia dealing with this COVID-19 vaccination data as it relates to how your vaccines are being rolled out? Specifically, are there any health facilities and other stakeholders, such as your private health facilities, the labs, the ports of entries, among others, that are reporting this data? Are they just sitting on it? Are they making use of it? Is the Ministry of Health aware of this data through their reporting? How has the ministry managed to cope with this data if it is being reported under its information management systems? And are they using it for decision making?
Thank you. So basically, Zambia also has some issues related to the COVID-19 vaccination data. I'll mention just about 2 for now. So the issue is that at first, Zambia didn't have adequate gadgets such as tablets for data entry, especially in the mobile vaccination sites. And then the data clerks had internet network challenges in some areas of operation. So the data for the clients who have been vaccinated is entered on the DHIS2, which is DHIS2 tracker, which is installed on the tablets, which the Ministry of Health uses as a data system or platform. So the data for the people who are vaccinated helps to plan for the distribution and monitor the stock balances and consumption of the vaccines. Then all the facilities or the vaccination sites across the country are able to reporting this data as they are conducting the vaccination, and the reports are extracted from the DHIS tracker. So what is it that the ministry or the government is using with this data that they are able to collect from the DHIS2 tracker? So the DHIS2 tracker uses the data to detect the vaccine uptake and coverages achieved since the inception of the program. So since the clients are entered in the system, the information officer is able to go in the system and check the vaccine uptake and be able to calculate the coverages against the target population. The second point is that the system is also able to show the vaccinated population according to the tiering system, as indicated in the NVDS. If you recall, I mentioned that as Zambia, we had a system where we had tiered health workers, congregate settings, those with comorbidities, and the other sets of population. So if you go in the DHIS2, you're able to show the vaccinated population according to the tiering. So we know how many health workers are vaccinated and those other target populations. So the data dashboard also assists with the redistribution of the vaccines according to consumption and also assists in follow-ups. For this one, what I can explain is probably if a certain amount of vaccines were distributed and then looking at the uptake, some provinces or some areas would have high consumption rates, which will help in logisticians to make a decision to say, maybe we take some vaccines to this site and this site, because due to using the information that they get from the data dashboard. Thank you.
Thank you very much, Bianca. There's a lot that we are learning. And based on all that you have just been sharing with us, reflecting on these lessons, what has happened using the lessons that you've been sharing with us? Are there any lessons that you can share with us about Zambia's journey on the introduction and implementation of the COVID-19 vaccine?
Well, there are some few lessons that Zambia is able to share on the vaccine introduction. The first one is there's improved stakeholder engagement at all levels. There's also dissemination of information at all levels. Then all the virtual meetings to be followed by on-site mentorship or technical support to the staff and the vaccination sites. Then there's also enhanced media engagement at all levels. This is to encounter the misinformation. There's dedicated meetings with traditional civic leaders. This was also a key in starting the actual vaccination program. Capacity building for health workers before vaccination also helped in sensitizations. This helped also in the dissemination of information also to the clients by the health workers. Then adequate funding is required at all stages of implementation. So the other point is the use of microplans. This one, the use of microplans helped. So the use of microplans helps in identifying the target populations in specific districts of operations. Then there was good political will, which led to people trusting the vaccination program. In that, the time of the launch in April, we had the Minister of Health and other senior and prominent officials of government, both government and private, who were vaccinated at the same event. So the other lesson is that it has helped to take a health systems approach to the COVID-19 vaccination. This has helped, the COVID-19 vaccination has helped with strengthening the systems of the routine immunization. Thank you.
Wow, Bianca, there's so much to learn from Zambia, and I'm hoping that our listeners have appreciated the successes that Zambia is going through as they continue to implement the COVID-19 vaccination program. But also there are lots of gaps or challenges, as Bianca mentioned. So I would like to call upon our listeners, hoping that you have picked enough, to share with us, is there a specific country that would like to reflect on some of the conversations that Bianca shared with us? For instance, what could have happened in Uganda, in other countries when the COVID-19 vaccination was introduced? Anybody would like to share with us? Anybody would like to first reflect on the conversations that Bianca just shared, the lessons we have learned? Otherwise, I could straight away go to these questions. There's one that came from Mark. Mark is asking, what's the open data policy of the Zambian Ministry of Health in terms of baseline health facility data? Bianca, kindly feel free to answer, but I noticed there are several other listeners from the Ministry of Health. Over to you, Bianca.
Thank you. So as Zambia, we also have a data protection policy in our laws, and the data is not easily accessed by individuals. So the people that are able to access the data, they have to be given permit to access that data and use it for decision making. Thank you. I can be guided. Thank you so much.
And there are loopholes along that process? And it being COVID, wouldn't it necessitate real-time actions or decisions on who should access, who shouldn't access? Has the ministry come up with some kind of SOP, standard operating procedure, on immediate accessing of this health data, Bianca? Just in relation to your submission.
For the Zambia, the Ministry of Health has a department or a committee called the Monitoring and Evaluation Committee. So that committee has also set up their own set of SOPs on how the data is accessed. That SOP is in place. Thank you.
Okay, thank you very much, Bianca. We also have two questions from Thomas. Was there pre-registration of target groups as part of micro-planning? If so, what efforts have been made to ensure that all target groups in every community had access to the registration process? Over to you, Bianca.
Okay, thank you. So as I stated in my earlier explanation, the target groups were, there was no pre-registration of the target groups. So what we were looking was, we were looking at the actual number of people in that set of group or tier. So if it's health workers, we look at how many health workers, how many health workers, how many police, how many port officers, but the actual pre-registration was not done. As I mentioned, we had the challenge of limited time. Thank you.
What do you think could have been the effect to that? How did it affect the processes in place? The lack of pre-registration, or there was no effect, that everything just moved smoothly?
So probably one of the effects could be the issue of having some defaulters, because we have some defaulters towards that. So that could have been the effect of the lack of pre-registration. Thank you.
Thank you very much, Bianca. Thomas still had another question. What steps were taken to reduce open vial wastage that was encountered in the initial phases of vaccine rollout?
Thank you. Some of the steps that were taken to reduce open vial wastage. If you remember, or if you recall, I mentioned to say the program was done in how can I put it? There were different approaches that were used for the same activity. There was static and mobile and outreach. So to avoid this wastage, the teams were allowed to go out and actually set up sites where there are a lot of people, and then that would attract a lot of people to come through for the actual vaccination program. And the other thing that was done was sensitization. So before a team goes in a certain community, a lot of sensitization would be done, and so that by the time the team is going in a community or a certain place, the information is already there and people will go and access the vaccine.
Okay, thank you very much for that submission, Bianca. Chilunga is asking, what has been the impact of the COVID-19 response on routine immunization? First answer that, and then we proceed with the other breakdown.
Sorry, you can come again?
What has been the impact of the COVID-19 response on routine immunization?
Okay, so on the impact of COVID on routine immunization is that it has helped to strengthen the system because some of the programs, some of the aspects of the immunization program are going on well. Especially, I can cite IFE reporting because people in the facilities districts have been trained in IFE reporting. So that has helped in that even in other immunization programs, the IFE reporting will improve.
Okay, great. So has the ministry used any digital health solutions to facilitate rapid training of vaccinators or other frontline health workers? If so, what has been the country's experience?
I stand to be corrected, but I think I mentioned to say the health workers who were supposed to take part in the program received their training through virtual. So the training were conducted through virtual for the people who were supposed to conduct the same vaccination. Thank you.
Do you have specific names for these virtual tools that were used? Other countries, we could learn from them.
So we, as a country, we came up with the training materials that we developed, which were according to guidelines under the WHO SAGE. So those are the materials that we're able to share as we're conducting the virtual trainings.
Okay. Any specific reflection on this training with the health workers while they were using the virtual tools?
Just come again, I couldn't get that.
Any specific reflection on the country's experience while they were training the frontline health workers and vaccinators using the virtual tools?
So the virtual trainings, as experience, it didn't have much effect because it was supposed to be followed by the on-site mentorship and training.
Okay. So Bianca, thank you very much, but I'm still calling upon colleagues to our listeners to evidence that they are learning a lot from Zambia's experience. And Tony, thank you. Has there been any events that have required Zambia to change their plans rapidly along the way? Bianca, over to you.
I can point to one event. So as I stated initially, our first target group was health workers. So when the vaccine came and it was deployed, the health workers had, they were shunning, or there was low uptake of the vaccine among the health workers. So because of that, the plan changed, and we had to allow now all the different tiers or the groups of the population to access the vaccine.
Okay, thank you. That was quite very helpful. Any other reflections on the lessons Bianca just shared with us, listeners? Or have we learned so much that we would like to carry forward in our respective countries? Especially on the strength, but also the strategies they use to address some of those gaps that Bianca mentioned.
Yeah, thank you, Dr. Josephine. This is Hassan, and apology if this has been, the question has been asked. We are, I'm based in Tanzania and we're currently introducing COVID vaccine. And then I think one of the things we're seeing is that there is sort of a general loss of following up on the other routine immunization services. The focus is exclusively on COVID vaccine, and then less attention is paid to other, activity related to other routine vaccination. Has that been the case in Zambia, and whether what have they done? Because I think it might have some impact in our routine immunization in terms of coverage in near future. Over.
Bianca?
Okay, thank you so much. I agree with you. There has been a lot of impact on the routine immunization because of the COVID. But as I stated, because of the COVID vaccine implementation, we've improved the system of the routine immunization program. And then the routine immunization, we've tried to work within the COVID-19 guidelines or the 5 golden rules, which are masking, sanitizing, and the rest. So at facilities, we still are able to reach out to the mothers or the caretakers as they bring their children. In that, we are able to put in the guidelines of COVID-19 prevention. Thank you.
Thank you very much, Bianca. Paul still has another question. Do you use the DHIS2 to track the distribution of the vaccine to its service points, or is it just being used to track usage at the vaccine centers?
Thank you so much. So for distribution, we have another system that the country is using, which is called logistical management system, which is Logistimo, that is used by the logisticians for the distribution of the vaccine. So we're using the DHIS2 and the Logistimo system. Thank you.
Okay. Bianca, you've done us so proud. On behalf of the Ministry of Health, Zambia seems to be doing great with managing this COVID-19 vaccination implementation program. And honestly speaking, I think I will need to share on some of these lessons with our own ministry here back at home. So Dennis would like to find out how we are managing the routine immunization and COVID vaccine at facility level. But I think Bianca mentioned something already, perhaps just for Dennis to get it more clearly with emphasis at facility level. Bianca, over to you.
Okay. So basically there are sites in each district where the vaccine implementation or the COVID vaccine is being given. So at the beginning, we were giving out the COVID-19 vaccine at the facilities. So this was becoming a problem due to the high numbers of people that were coming to access the vaccine, which could have also led to further spread of the COVID-19 disease. So as a country, as I mentioned, we looked at outreach sites as a strategy. So we were able to open up other sites within the same districts where the people were able to access the actual vaccine.
Wow. Dines, I suppose you're happy. You can give some feedback to Tanzania Ministry of Health. Now, I think most of our listeners are happy with the reflection on these lessons in Zambia. And on that note, allow me to thank very much Bianca Chifwero on behalf of the Ministry of Health, Zambia, for sharing their wonderful lessons on the implementation of the COVID-19 vaccine program. Personally, I have learned a lot, and my assumption with all the questions that came through, I can conclude that all the listeners have picked one, two, or everything that Bianca has shared. Thank you very much, Bianca. This has been very helpful. Thank you for your time. Thank you for sharing the lessons with us all. And I would like to extend an applause to the Ministry of Health, Zambia. I think you're doing a great job. It's very clear that other vaccination programs, we are not abandoned just because of the pandemic. You seem to have well aligned with all the other programs to make sure that the health system continues functioning efficiently and effectively. At this point, I would like to welcome back the host, Catherine. Please, over to you. Thank you. Catherine?
Sorry, I was talking to myself. I forgot I was muted. Thank you very much, Professor. That was a very well-driven and engaging discussion. And I'm sure that, like you mentioned, the audience were able to pick one or two lessons, because I also personally learned a lot. I know I live in Zambia, but you know, we've been interacting with quite a number of countries on this issue. And it's amazing what Zambia has done. Obviously, the issues that they spoke about, the challenges that haven't been unique to Zambia, but I think it's more of the strategies that, you know, or the approach that they use to address these challenges, which are probably, some of them are unique to Zambia. So listeners, we've come to the end of the webinar today, and obviously I'd like to thank you so much for joining us in this discussion. And once again, a very special thank you to our moderator, Professor Nabukenya, for not only leading the discussions, but you know, drawing out those important lessons. And I would like to extend a special gratitude to Bianca, who spoke on behalf of the Ministry of Health for Zambia, for, you know, graciously sharing and elaborating on Zambia's experience with the vaccine introduction. So with the BLN, we're grateful to everyone. And like I mentioned earlier, this webinar has been recorded, and of course we'll be sharing the access link with all of you in due course. And I would like to encourage you to continue connecting with us. And I would like to invite you to join us again, in the next few months, where we'll be taking a look at yet another facet of the deployment of the COVID COVID-19 vaccine. For instance, we'll probably be zeroing into issues to do with vaccine hesitancy. I think that has been one of the biggest problems that most countries are facing. And I would also like to hear what the experiences have been from the private health facilities and the like. So until then, please, would like to ask you all to continue keeping safe and following those key guidelines like observing social distancing, masking up, and remembering to wash your hands and sanitize frequently, and also to encourage those who haven't been for their vaccine, for their COVID-19 vaccine, to do so. So until next time, bye.
Bye.
Thank you.
Thank you.
Bye-bye.
Bye.
Bye.
Bye, everybody. Bye, Catherine.
Bye.
Bye, everybody.
Bye-bye.